Let's dive into the electrocardiogram, or ECG. The heart's electrical activity can't be seen with the naked eye, but electrocardiography allows us to record it. What we see is the electrocardiogram, which reflects each phase of the cardiac cycle as specific waveforms on a monitor or on ECG paper. To get an ECG, electrodes are placed on the body at specific sites. These electrodes have two important parts: an adhesive layer to secure them to the skin, and a conductive layer that reduces the skin's electrical resistance, allowing signals to pass clearly. Preparing the skin properly makes a big difference. Rubbing the skin gently with gauze or the sandpaper edge of the electrode can expose the inner layer of the epidermis and improve conductivity. Soap and water cleaning is best, while alcohol should be avoided because it can actually increase resistance. If chest hair is thick, it may need to be clipped to ensure good contact. Without solid adhesion, you'll see artifact on the tracing, extra squiggles that don't belong and can distort the real rhythm. The number and placement of electrodes depend on the type of ECG you're doing. Most continuous monitors use 2 to 5 electrodes placed on the limbs and chest. Each arrangement creates an imaginary line called a lead, which acts like the eye of a camera. It only sees the electrical activity directly in front of it, so the waveform on the screen reflects that particular lead's perspective. Changes in waveforms can be due to changes in the impulse itself or changes in how and where the lead is positioned. The electrodes attach to cables, and those cables can connect to different devices. A standard 12-lead ECG machine gives an immediate recording at the bedside. In intensive care units, patients are usually connected to hardwired monitors for continuous reading. Telemetry allows a patient to wear a small transmitter that sends signals by radio waves to a central monitor. Some patients go home with continuous monitoring devices, like Holter monitors or patch monitors, that record data over days. Others may use event monitors or loop recorders, which can be worn on the wrist or implanted just under the skin to capture rhythms when symptoms occur. In special cases, an electrophysiology study is performed by placing electrodes directly inside the heart to pinpoint arrhythmias and guide treatment. During open heart surgery, temporary pacemaker wires may be sutured to the epicardium and brought out through the chest wall. These wires can be used for pacing or to obtain atrial ECGs for better diagnosis of tachyarrhythmias. For standard 12-lead ECGs, 10 electrodes are placed, 6 on the chest and 4 on the limbs. Limb electrodes should be placed on non-bony, low-movement areas to reduce interference. The limb leads create the first 6 views: leads 1, 2, 3, AVR, AVL, and AVF. The 6 chest electrodes give us the precordial leads, V1 through V6. Placement must be exact. Finding the right intercostal spaces is critical because errors in placement can lead to misdiagnosis. Additional leads may be added in special cases, such as right-sided leads for suspected right ventricular damage. Now let's look at the components of the ECG itself. The ECG graph paper has a standard grid. The horizontal axis measures time and rate, while the vertical axis measures amplitude or voltage. A wave moving upward is a positive deflection. Downward is a negative deflection. Each waveform should be examined in relation to the others for accurate interpretation. The ECG is composed of waves, complexes, intervals, and segments. The P wave reflects the impulse beginning in the SA node and spreading through the atria, representing atrial depolarization. Normally, it is less than 2.5 millimeters in height and 0.1 seconds or less in duration. The QRS complex represents ventricular depolarization. The Q wave is the first negative deflection after the P wave. The R wave is the first positive deflection, and the S wave is the first negative deflection after the R. Small letters are used if the waves are shorter than 5 millimeters, and capital letters if they are taller. The QRS duration is normally less than 0.12 seconds. The T wave follows the QRS and represents ventricular repolarization, or the resting phase. It usually points in the same direction as the QRS. Atrial repolarization does happen, but it is hidden inside the QRS complex. The U wave, which is rare, may follow the T wave and is thought to reflect repolarization of the Purkinje fibers. It is sometimes seen in patients with low potassium, hypertension, or heart disease. The PR interval is measured from the start of the P wave to the start of the QRS complex, reflecting the time needed for atrial depolarization and conduction through the AV node. It normally ranges from 0.12 to 0.20 seconds. The ST segment begins at the end of the QRS and ends at the start of the T wave, representing early ventricular repolarization. It should be flat or isoelectric and is closely examined for elevation or depression, which can signal ischemia. The QT interval, measured from the start of the QRS to the end of the T wave, represents the total time for ventricular depolarization and repolarization. It varies with heart rate, age, and gender, and may be corrected as a QTC. The normal QT interval is about 0.32 to 0.40 seconds when the heart rate is 65 to 95 beats per minute. Prolonged QT is dangerous because it increases the risk of torsades de pointes, a potentially lethal arrhythmia. Finally, the TP interval is the flat line between the end of one T wave and the beginning of the next P wave. This is the true isoelectric line. Both the PR segment and the TP interval can be used as reference points, but the TP interval is more reliable because ischemia can distort the PR segment. The PP interval is measured from one P wave to the next and tells us about atrial rate and rhythm, while the RR interval is measured from one QRS complex to the next and is used to calculate ventricular rate and rhythm. So in summary, the electrocardiogram is our window into the heart's electrical system. From proper skin prep and lid placement to understanding each waveform, every step matters for accurate diagnosis and monitoring.